The following podcast is part of a certified educational activity titled Accelerating Personalized Care in CRC, the Prominent Role of Predictive Biomarkers and Immunotherapy Platforms in Early and Advanced Disease. Access the entire activity and complete the post-test at peerview.com/JXZ860. Downloadable slides and practice aids are also available.
Hello, and welcome to Accelerating Personalized Care in Colorectal Cancer. My name is Andrea Sursek, and I'm a medical oncologist at Memorial Sloan Kettering Cancer Center in New York. I'm joined by Jenna Sinapoli, clinical trials nurse practitioner at Memorial Sloan Kettering, and we'll be discussing the prominent role of predictive biomarkers and immunotherapy platforms in early and advanced disease. Thank you, Jenna, for joining.
Thank you, Andrea. Happy to be here.
Okay, let's get started with our goals for today. The goals for today are to discuss the role of predictive biomarkers and guideline-directed approaches to inform decision-making in colorectal cancer, to enhance your understanding of the latest clinical trial evidence and guideline recommendations supporting the use of immunotherapy for CRC, equip you with skills for personalizing treatment plans with immunotherapy based on current clinical trial evidence, guideline recommendations, and biomarker findings, and to provide guidance on team-based strategies to address practical aspects of care with immunotherapy, such as patient consultation and engagement, care coordination, and immune-related adverse event management. Our first module is going to discuss leveraging molecular profiling and multidisciplinary care to overcome challenges in CRC. Currently, there are several shortcomings in the treatment of patients with advanced metastatic colorectal cancer. The number one is that a large number of patients do not receive biomarker testing. So that includes no testing for MSI, RAS, BRAF, or HER2, which is actually part of our guidelines. Many community centers don't do biomarker testing and also don't do any type of genetic counseling for colorectal cancer patients. And this applies beyond just, testing at any time. It's not done in the first line setting, and we certainly have indications for decision-making based on biomarker status in the first line setting. And then even beyond that, we have a proven benefit of a number of targeted agents, including immunotherapy, beyond first line and second line and in the refractory setting. And we find that many patients actually receive sort of recycled chemotherapy, don't necessarily receive appropriate biomarker-directed therapy, even in later lines of therapy. So really, it is a huge shortcoming that biomarker testing is not being done, or if it's being done, it's not necessarily monitored closely by the treating oncologists. Current guidelines for molecular testing in metastatic colorectal cancer. So all patients diagnosed with metastatic colorectal cancer should be tested for the following: RAS mutations, which include all RAS, so NRAS and KRAS, BRAF mutations, mismatch repair protein status, either by immunohistochemistry or MSI status, and then HER2 amplifications. These are really the sort of four critical boxes that need to be addressed for all patients with metastatic colorectal cancer. Microsatellite instability high, or MSI tumors. So there's a few ways by which these tumors result. One are caused by a germline or hereditary non-polyposis colorectal cancers, also known as Lynch syndrome. And they're due to hereditary mutations in one of the mismatch repair genes, either MLH1, MSH2, MSH6, PMS2, or EpCAM. These patients are obviously identified by germline testing, and why germline testing is so important, especially if we find MSI high tumors, because they have an increased risk of cancer over their lifetime, including colorectal, endometrial, stomach, ovarian, urothelial, as well as other cancers. And then another way that these tumors can arise is what's called acquired MSI. So most of these are due to hypermethylation of the MLH1 promoter and epigenetic silencing of MLH1. There can also be a double somatic MSI caused by mutations in MMR genes. And the two testing methods for both of these are either via immunohistochemistry, so IHC for loss of one or more of the mismatch repair proteins, or PCR-based testing for MSI to identify variation in genomic repeats, or of course, next generation sequencing, which gives us a broad panel of mutations, including MSI status. And we've learned that discussing molecular testing with patients is important and is in their interest as well. So this is based on a survey of 66 patients and what they want to know about. So 88% of them wanted to know the benefits of testing, how the tests will affect their treatment, and then equally as important is implications for family members depending on the results of the test. And whether or not we can predict the seriousness or aggressive nature of the disease with the biomarkers that we test. And then, of course, what is the purpose of the test? What will we use the results for? So really the bottom line in terms of patients is patients want to know, they're interested in this testing and they're interested in the discussion, either from their physician or their nurse, to have this discussion to better able to guide their care, and then also potentially for testing of their family members if it's indicated.
So Richard is a 68-year-old patient with newly diagnosed metastatic colorectal cancer with primary in the cecum. His CBC shows hemoglobin 11, platelets 172, bilirubin 0.9, creatinine 0.8, and his ECOG is 0. What would be the first steps in selecting treatment?
So initially I would think about, obviously, if this is advanced disease, if this is early stage disease, clearly here he has metastatic disease to the liver. We think about the disease burden in the liver. Can he undergo upfront surgery, or does he need systemic therapy because he has more disease in the liver? That's really kind of my first assessment, and how fit he is then for systemic therapy.
And how would you approach baseline tumor assessment, and which biomarkers should be tested up front?
So this is really important. So he has a cecal or right-sided primary, metastatic disease to the liver. He's in good shape for systemic therapy, more disease so he needs systemic therapy, so surgery up front wouldn't be an option. And we would look certainly at biomarker testing as a first maneuver. I would do immunohistochemistry on the biopsy to look at mismatch repair proteins. If the tumor is mismatch repair deficient, I would feel comfortable then offering immunotherapy as a first-line treatment just based on immunohistochemistry. If we're able to obtain a bit more in-depth testing with next-generation sequencing, that is definitely something that I would send off right away, and that would include testing for RAS status, BRAF, HER2, as well as MSI. So all of those are really important in making this decision. In terms of RAS status, because it's a right-sided tumor, even if he was RAS wild type, that anti-EGFR therapy would not be an option. But BRAF is certainly a possibility in this patient with the right-sided primary. HER2 could be treated on a clinical trial in the first-line setting, so that would be an important thing to evaluate also for HER2 amplification. Then, of course, MSI confirmation either by PCR or next-generation sequencing here would be important, and that would then enable me to give upfront immunotherapy if he had a mismatch repair deficient or MSI high tumor. So just to mention, the Colorectal Cancer Alliance is a patient advocacy organization with numerous resources for patients. And if you download the practice aid, you will have a link to all of the resources available through the Colorectal Cancer Alliance. So moving on to our second module, we're going to be discussing collaborative applications to integrate immunotherapy platforms in advanced stage colorectal cancer. So just a word about immune checkpoint inhibitors. They block T-cell inhibitory signals. So some of our agents that we use are target PD-1 or PD-L1, and they work by blocking T-cell inhibitory signals. So they basically remove the brake on the body's immune system. And the landscape of immunotherapy is very rapidly expanding. We've seen numerous studies demonstrating benefit of immune checkpoint blockade in many different tumor types as single agent as well as in combination. So PD-1 alone or PD-1 in combination with CTLA-4. And this is why it's critical to test for biomarkers, particularly MSI in the case of colorectal cancer, because it could really guide decisions regarding the use of immunotherapy. And we know that in MSI tumors or mismatch repair deficient tumors, there's a significant benefit to immune checkpoint inhibitors and perhaps less of a benefit, certainly in certain patients with MSI tumors, to chemotherapy or targeted agents. NCCN guidelines now recommend immune checkpoint inhibitors in any line of therapy for mismatch repair deficient or MSI high metastatic colorectal cancer. So patients previously untreated, such as the case of our patient Richard that we were discussing, with an MSI high tumor, the options include dostarlimab, which is a PD-1 monoclonal antibody, combination of nivolumab and ipilimumab, which is a PD-1 monoclonal antibody with an anti-CTLA-4, or pembrolizumab, which is a monoclonal PD-1 antibody, as first-line treatment. And then, of course, with close follow-up, as we do with chemotherapy, with evaluation every 2 to 3 months, and then proceeding with standard of care following immunotherapy. So just to show you some of the trials that led to these guidelines and led to the approval of immunotherapy in MSI disease, the Keynote 177 study actually looked at pembrolizumab versus investigators' choice of chemotherapy in the first-line setting in mismatch repair deficient or MSI tumors. And you can see by the beautiful separation of the curves, there was clearly a progression-free survival benefit with first-line pembrolizumab over chemotherapy in this patient population. And the final overall survival and anti-tumor response, the overall survival endpoint is a bit tricky in this trial because many patients, since it was a first-line therapy, many patients who were on the chemotherapy arm were able to get pembrolizumab at the time of progression. In fact, 60% of them received pembrolizumab in the second line or some combination of immune checkpoint blockade in the second line after progression. But there was a significant benefit in terms of anti-tumor response with pembrolizumab over chemotherapy in this patient population. And likewise, the phase 3 Checkmate 8HW study asked the question of first-line nivolumab plus ipilimumab or nivolumab alone versus standard chemotherapy in mismatch repair deficient MSI high metastatic colorectal cancer. And the data have not fully been presented, but so far what has been presented is the comparison between the chemotherapy arm and the combination of nivolumab and ipilimumab with a significant benefit in progression-free survival. In fact, it was not reached in the Ipi-Nivo group over a PFS of 5.9 months in the chemotherapy arm in this in MSI high metastatic colorectal cancer in the first line setting, really demonstrating this robust benefit of upfront immunotherapy in patients who are confirmed to be mismatch repair deficient and MSI. And I think some of the benefit here, even more so is emphasized by the fact that patient selection was likely much better here than in the earlier Keynote 177 study, just really showing that with appropriate patient selection, mismatch repair deficient or MSI high tumors, these patients really do benefit with immunotherapy upfront. And then there is an ongoing phase 3 study, the COMMIT study with SWOG S1610 of atezolizumab, so a PD-L1 monoclonal antibody in first-line MSI high mismatch repair deficient colorectal cancer. And here the primary endpoint is progression-free survival, similar to the design that we've seen in the Keynote 177 and the Checkmate 8HW study, but asking about the benefit of atezolizumab alone versus atezolizumab plus bevacizumab plus FOLFOX as first-line therapy in metastatic MSI-High colorectal cancer. So the data, this trial is currently ongoing. We've discussed the benefit of immunotherapy in the first-line setting. What about the second-line setting? If you don't have biomarker results back quickly enough, the patient initiates chemotherapy. Is there still a benefit in treatment with immunotherapy of mismatch repair deficient tumors or MSI-High tumors after progression on chemotherapy? And the short answer is absolutely. But just to discuss the trials in a little bit more detail, the Keynote 164 study was really the first to demonstrate significant benefit of pembrolizumab in previously treated MSI-High or mismatch repair deficient metastatic colorectal cancer, with a benefit in progression-free survival and a benefit in overall survival in this patient population, even after progression on standard lines of therapy. And the Checkmate 142 study echoed these results. This was a combination of nivolumab and ipilimumab in pretreated patients. And the 4-year follow-up really showed unbelievable progression-free survival as well as median OS benefit in this population, where neither has been reached, which is remarkable for patients that had progressed through chemotherapy arms. Again, really stressing the importance of obtaining biomarkers, obtaining mismatch repair deficient or MSI status, and then rechecking it again, even in patients where they might have progressed on chemotherapy, to see if this might be an option in subsequent lines of therapy. And likewise, the Garnett study of dostarlimab in patients with mismatch repair deficient MSI-High advanced or recurrent colorectal cancer also showed a significant benefit of dostarlimab in this patient population, even after being heavily pretreated with chemotherapy.
So following a multidisciplinary screening evaluation, Richard is found to have KRAS and BRAF wild type, no HER2 amplification, and mismatch repair deficiency confirmed with next generation sequencing. How would you now approach this treatment selection for this patient?
So these are, in my opinion, very exciting results. And I would discuss with Richard that his tumor is mismatch repair deficient and MSI-High, and that this enables us to treat him with upfront immunotherapy. And we can either choose single agent PD-1 or combination, which is typically decided on based on symptomatology. I think we have very good data for single agent, as we've just discussed. And so I think this is a very exciting treatment option for him in the first line setting. We've discussed immunotherapy options for patients with mismatch repair deficient or MSI-High tumors in advanced disease, from first line all the way to the refractory setting. But what about early stage disease? The majority of patients with early stage cancers, colorectal cancer, can undergo surgical resection, and then there's a decision on whether or not they should receive adjuvant chemotherapy based on the pathological status. The ATOMIC study is addressing the question of the benefit of adjuvant chemotherapy alone or chemotherapy plus atezolizumab in this patient population. The data are currently maturing, and we should hear the results of that likely in 2025. But what about patients with rectal cancer? The rectum is approached differently than the colon with early stage disease because it's located in the pelvis. And so for patients with rectal cancer, the treatment is not upfront surgical resection, but is actually a combination of chemotherapy, chemoradiation, and then surgery. And the goal there really is of course, for cure, for pelvic control. There has been a lot of movement towards non-operative management because of the location of the tumors in the rectum. And so the question of, would this patient population benefit from neoadjuvant immunotherapy if they had mismatch repair deficient or MSI-High tumors? to try to optimize the responses and potentially omit surgery was asked by this study, the NCT 041657772 study, where dostarlimab, the PD-1 monoclonal antibody, was introduced first to patients with confirmed stage 2 or 3 rectal cancer that were mismatch repair deficient by immunohistochemistry. And the patients received 6 months of dostarlimab every 3 weeks, followed by full radiographic and endoscopic assessment. If they had a clinical complete response, they could undergo non-operative follow-up, so no further interventions, no chemotherapy, no radiation, and no surgery, just follow-up after 6 months of dostarlimab. If there was still disease, they could then receive standard of care chemoradiation, and then again could omit surgery if they had a complete clinical response. And if they didn't, then they would undergo standard of care tumor resection. And so there were 2 primary endpoints here. One is overall response rate to either dostarlimab alone or in combination with chemoradiation. And then the second endpoint was a pathologic response, complete response in the patients who went all the way through the surgery, or a sustained clinical complete response for 12 months after completion of dostarlimab alone, or in combination with chemoradiation if that was needed. And there was a lot of sample collection for correlative scientific analyses along the way. So these were the most updated results as of ASCO 2024, where 100% of the patients, 42 patients at the time, had a clinical complete response to dostarlimab alone. So incredibly sensitive tumors to upfront PD-1 blockade with dostarlimab, where all the tumors disappeared completely, just with immunotherapy, no need for any other intervention, and all patients were followed non-operatively. And here, the patients achieved the second primary endpoint of a sustained clinical complete response for 12 months, meaning that there were no local regrowths. And so really just incredibly sensitive disease early on when treated in the neoadjuvant setting. So based on the results of the trial that were actually presented initially in June of 2022, the NCCN guidelines changed the recommendation for mismatch repair deficient locally advanced rectal cancer and recommends now neoadjuvant PD-1 blockade for this patient population, which includes dostarlimab, nivolumab, or pembrolizumab as the first treatment option. And then as the trial was designed, with the opportunity of surveillance or non-operative management if the patient has a clinical complete response, but if there's persistent disease after 6 months, they can undergo standard of care treatment or total neoadjuvant therapy for locally advanced rectal cancer. And the ASIA-1 study is a global confirmatory study, which has actually completed accrual, very similar design to the single institution neoadjuvant dostarlimab study, but 150 patients with untreated, locally advanced mismatch repair deficient MSI-H rectal cancer received dostarlimab for 9 cycles or 6 months total, and then have a complete response assessment. If the tumor has completely disappeared or the patient has a clinical complete response to dostarlimab alone, they can be followed with non-operative management. If they have residual disease, they can undergo standard of care total neoadjuvant therapy or surgery at the discretion of the treating physician at that time. And so this will be very exciting results of this study. It's a global study and will hopefully provide this treatment for all patients with mismatch repair deficient locally advanced rectal cancer.
Now we're going to address practical aspects of care with immune-based therapy. So many patients receiving these agents do not develop any side effects, but you do get these toxicities of skin changes, pruritus, erythema, dermatitis. Endocrine is often involved. Hypothyroidism is often seen, and we do get a thyroid panel on our patients at baseline and every few cycles. These are usually very manageable. Immunotherapy can cause inflammation of any organ, colitis, nephritis, pancreatitis, pneumonitis. Pneumonitis, patients can be very short of breath and hypoxic. These symptoms need to be recognized very promptly with imaging rapidly so we can intervene very quickly. Immune-related AEs can occur relatively early, but they can arise at really any point, so it's important not to let your guard down throughout the duration of therapy. The earlier these are recognized and the sooner supportive care measures are started, the sooner the patient can restart therapy and get back on drug and benefit if it is appropriate to restart. For minimal cases, grade 1 treatment with checkpoint inhibitors can usually continue with careful monitoring. Oftentimes for grade 2 toxicities, we do have to hold treatment depending on the toxicity. In cases where we wouldn't hold, for example, grade 2 dry skin, we would get dermatology involved and definitely start on topical medications. For grade 3 and grade 4 toxicities, we are always holding and potentially even discontinuing study treatment permanently. So Richard initiated an upfront immunotherapy regimen and is now having 4 to 6 stools above baseline. Establishing all patients' baseline history is critical to understanding when medical intervention is necessary. And for participants with grade 2 or higher diarrhea where colitis is suspected, we would have them present to the nearest hospital, have a GI consultation and endoscopy to rule out colitis, and administer high-dose steroids, which would eventually be followed by a taper. In terms of patient education, we would advise Richard to drink liberal quantities of clear fluids, but oftentimes when they present to the hospital, they are made NPO, so fluid and electrolytes should be substituted via IV infusion. Supporting effective communication. Multidisciplinary care is really critical. There are rarer toxicities that are seen, and that's when it's important to bring in the relevant subspecialists to assist with their management. Rheumatology, endocrinology, sometimes ophthalmology is even needed, and having a point of contact in all of these divisions so symptoms are managed early and quickly. The oncology nurse's role. Nurses play a key role in educating patients about side effects and emotional and practical support. You want the patients to feel motivated and prepared and empowered and understand the role of the therapy they're receiving. Self-management is important to discuss, but you want patients to know when it's gone beyond self-management and when they need to opt into healthcare to help them with the toxicity they are experiencing. Dosing schedules can differ among agents and between cycles of a specific agent, so calendar and electronic tools can be immensely helpful to convey dosing schedules to patients. Engaging patients in shared decision-making has a significant impact on the patient's psychological well-being, adherence, and confidence in the provider. Social work and support groups like NOCC are crucial for patients to provide emotional support and improve overall well-being and quality of life. Clinical trials are essential for advancing medical science as they help test the safety and effectiveness of new treatments and medications. For patients, participating in a trial offers early access to therapies that may not be available otherwise. Beyond personal benefit, they also play a crucial role in helping future patients by contributing to medical research. You can access resources pertaining to clinical trials from the Colorectal Cancer Alliance website.
So for our last module, we're going to discuss the latest with perioperative immunotherapy in resectable disease and really extending the progress to earlier stages of colorectal cancer. As we discussed with rectal cancer, the approach of neoadjuvant immunotherapy was critical because it really enabled us to omit surgery altogether and ultimately to omit actually all standard modalities of treatment. In colon cancer, the standard approach is upfront resection and then a decision on adjuvant immunotherapy in that setting. And as we mentioned, the ATOMIC study will answer that question of whether or not there is a benefit in MSI-high mismetric deficient resected colorectal cancers of the addition of adjuvant atezolizumab to a chemotherapy backbone. But what about introducing neoadjuvant immunotherapy in this patient population? So the studies thus far have really focused on neoadjuvant immunotherapy for a relatively short period of time, followed by surgical resection, and then an evaluation of a pathologic complete response as the primary endpoint. And there's really three main studies that have asked this question. The first is the Niche 2 study, which was an extension of the Niche 1 study that showed a benefit of MSI-High colon cancer to the combination of ipilimumab and nivolumab for just 1 month. And so here, 111 patients were treated with 1 dose of ipilimumab and 2 doses of nivolumab, and then underwent surgical resection. And 68% of them have a pathologic complete response with a benefit in disease-free survival. So clearly a very sensitive tumors to immunotherapy as well. And the MD Anderson group, led by Dr. Ludford, also published their experience with 6 months of pembrolizumab in patients with MSI-High colon cancer that underwent resection, with a very similar pathologic response rate of 65%. And then Dr. Hu in 2022 published in Lancet Gastroenterology and Hepatology the treatment of toripalimab, which is a PD-1 monoclonal antibody, for 3 months in 17 patients with also a pathologic complete response rate of 65%. So again, really showing that variable durations of therapy, but very sensitive tumors to immunotherapy as well. And of course, the next step here would be, would there be a benefit in extending this therapy and treating for longer periods of time? Or do all patients really need this, since all patients here, the way that these trials were designed, still received curative surgical resection? So the Azure 2 study is a randomized study with a target accrual of 711 patients with early stage resectable colon cancer that's untreated and mismatch repair deficient or MSI-High. And the disease is to be T4N2 or stage 3 disease by imaging. And the patients are randomized to either dostarlimab for 4 cycles, followed by surgical resection, and then adjuvant dostarlimab for an additional 6 cycles, or upfront surgical resection, and then a decision for chemotherapy based on pathological findings, so either chemotherapy or expectant observation. And I think this is an important study. It's actively accruing. It will teach us about the prediction of staging in this patient population with imaging, the need for immunotherapy, or is surgery alone sufficient in terms of benefit in disease-free survival and overall survival in the long run. And I think these are some of the questions that now remain in resectable colon cancer. We know that it's a sensitive population to immunotherapy. We don't know if it's necessary. And then I think a really important sort of forward-thinking step is, could we think about non-operative management here, really taking advantage of the high sensitivity of mismatch repair deficient MSI-High colon cancer to immunotherapy? And could we extend the experience seen in rectal cancer of non-operative management also to colon cancer, perhaps with longer duration of therapy that could also be achieved?
So Brenda is a 51-year-old rectal cancer patient exploring current neoadjuvant-based treatment regimens to manage her early-stage disease. Her CT cap is negative for metastatic disease, and IHC shows mismatch repair deficiency. Is neoadjuvant immunotherapy a reasonable option to consider?
Yes, absolutely. I'd say we have data to support neoadjuvant immunotherapy. It is supported by NCCN guidelines. I would certainly favor single-agent PD-1 blockade, dostarlimab, in this setting, given the positive data that we've demonstrated in the trial. But per NCCN guidelines, any combination of single-agent checkpoint blockade is acceptable.
And what timing or dosing considerations would there be around surgery?
I think the goal here, since this is a rectal tumor, would be treatment for 6 months, and then consideration of non-operative management if the tumor has responded completely or completely disappeared to neoadjuvant immunotherapy alone. And if there's residual disease, then we can think about resection or potentially a different form of total neoadjuvant therapy, such as chemoradiation due to the location of the tumor. So this would really depend on the location of the tumor and the response, because some rectal tumors can be quite low, which would then require an APR and a permanent colostomy. So those factors would play into consideration if the tumor didn't completely respond to PD-1 blockade alone.
And if the tumor was in the colon, would you consider IO via clinical trial?
I would. I think we have very robust data showing sensitivity of colon mismatch repair deficient MSI-H colon cancer to immunotherapy as well. So I think this would definitely be something to consider for this patient.
And would treatment decisions change if there was a POL positive mutation?
Yeah, so the POL mutated tumors are hypermutated, so they're not MSI high, so they don't come back as mismatch repair deficient or MSI high. We find the POL-E or POL-D mutations when we obtain the next generation sequencing, and we see these numerous mutations or hypermutated tumors. And this has been shown to be very sensitive to immunotherapy in the metastatic setting. So it's a very interesting question, and I think an intriguing question to think about treating these tumors even in early stage disease with immunotherapy. Would have to be potentially on a trial. It is not standard of care. It's not approved by NCCN guidelines, but I think it's definitely a patient population that would benefit from immunotherapy. So in summary, I think the most important things to think about for colorectal cancer is obtaining biomarkers. We make a number of decisions now based on biomarker status. It's critical in metastatic colorectal cancer, where we can determine first-line therapy based on RAS status, based on BRAF status, potentially for trials based on HER2 amplification, and of course, approved treatment for mismatch repair deficient or MSI high tumors in first-line therapy with immunotherapy. We have more and more evidence now in early stage disease, particularly in rectal cancer, that mismatch repair deficient or MSI high locally advanced or early stage rectal cancers can be treated with immunotherapy. It's in our NCCN guidelines. The results are remarkable, where patients may not need any form of standard of care other than PD-1 blockade alone. And then, as we've discussed, there are ongoing trials in early stage colon cancer as well, which are exciting and could potentially change treatment as well. So it's something very important to think about in really all stages of colorectal cancer. And as we heard from Jenna, it's critical to monitor the IRAEs from immunotherapy. Patient counseling is important, and I think patient communication is critical. And what we really stress a lot with our patients is just to alert the care team of any new symptoms, any persistent symptoms, and just communicate as much as possible, because these side effects are very manageable, particularly if caught early. Thank you for joining this PeerView educational program on immunotherapy options for colorectal cancer. Jenna, thank you so much for joining me.
Thank you.
Please download the slides and practice aids available on peerview.com. We hope you found this informative and helpful for your practice.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is developed with our educational partner, Colorectal Cancer Alliance. This educational activity is supported by an independent medical education grant from GSK. To access all materials for this activity, visit peerview.com/JXZ860.